On behalf of Oral Medicine and Radiology, KSR Institute of Dental Science and Research, I welcome you all to the CD program. I request our HOD, Dr. Ilunguvan, to address the gathering
now. Good morning, all. Good morning, Sharath.
Morning, sir.
I just first I want to talk about the title of this program. Many of you must be wondering what is monochrome and what we are going to do in unraveling the Enigma. Till the last part of a large part of the last century, imageology was mainly gray, shades between black and white. That is conventional X-rays. Even CT, MRI, everything was all shades of gray. So that is a single color. That's why it is monochrome. We have named it monochrome. And then first came the color Doppler, USG, that gave some color like red and blue. And of course, in this century, it has become more colorful because of 3D imaging, where you can see the color of the bone, and PET positron emission tomography, where it shows colors like blue, orange, etc. And thermography, there is one underutilized or still underdeveloped imaging modality, thermography, that shows a lot of colors. So it has become colorful, but the origin is monochrome. That's why we have called it monochrome. And unraveling the Enigma is we are going to talk about what it has done. Everything, and why we have chosen this day. This day is named after the great man Röntgen, the father of radiology, discoverer of X-rays. On a otherwise a normal winter evening in 8th November 1895, in a small laboratory somewhere in Germany, he noted a speck of light that went on to revolutionize the medical field. That's just a speck of light. Okay, this is I'm quoting from our old radiology textbook, Weidengoss. So to honor honor Röntgen, they have called this day as actually this is the day of discovery of X-rays, Röntgen Day or Radiology Day. And I am very proud to be a radiologist. And about I welcome you all to this CD program. And about the speakers, I consider myself privileged to be one of their teachers at different times. It gives me immense pleasure for to see their rise in the academics. They have what to say? They have more than fulfilled my wishes. I want all my students to excel in the field of oral medicine and radiology. They have done more than that. So I'm happy to welcome Anand and Satyaranjan. Today, as you all know, the climate and the rain is being a spoil sport, but still we'll go ahead. It's to see it. This number of participants, it may be increasing. It's quite good enough. People want to know, want to learn something from us. That's good. And I request our principal, Dr. Sharath Ashokan, to say a few words.
Very good morning to everyone present here. Good morning to the Department of Oral Medicine and Radiology. First, at the outset, I would like to congratulate Ilangovan sir and his team for organizing such an event on World Radiologist Day, and hearty Radiologist Day to all the oral medicine and radiology specialists. Thank the resource faculty, Dr. Satyaranjan Mishra and Dr. Anand, for accepting our invitation and for coming here and being ready to share your experience and knowledge amongst us. I wish the event all the very best, and I hope the participants will be benefited out of this. Happy World Radiologist Day. Thank you, sir.
Thank you, Sharad.
So thank you so much. We sincerely appreciate the way you encourage and support us always. Thank you once again, Sharad sir. And every year since 2012, November 8th has been celebrated as World Radiology Day. And the theme for this year is interventional radiology with the motto of special care to the patient. And that's why to mark this occasion, we are conducting this CD program on this day. Now I request Dr. Gomati, a reader in our department, to introduce the speaker for the first session. Gomati.
Thank you, ma'am. A very good morning to all present here. I feel very honored to introduce this sweet and ever charming and humble speaker of the day, Dr. Satyaranjan Mishra. Sir is a professor and head of the Department of Oral Medicine and Radiology, Institute of Dental Sciences, Shiksha University, Bhubaneswar. Sir pursued his BDS degree from Vinaya Mission's Lord Jagannath Institute of Dental Science, Bhubaneswar in 2003, and MBS degree from Savita Dental College and Hospitals, Savita University in the year 2008. And currently, sir is doing his PhD on oral potentially malignant disorders and oral carcinoma under Shiksha University, Bhubaneswar. Sir started his teaching career in the year 2008, and he is a reviewer of many reputed journals like Journal of Indian Academy of Oral Medicine and Radiology, Journal of Clinical Imaging Science, the Oral Oncology Journal, and Journal of Clinical and Diagnostic Researches, and so on. He has given many guest lectures in the various national conferences, and he has contributed chapters in the Handbook of Famine, Starvation and Nutrition Deprivations from Biology to Policy, and a chapter on nanoparticles too. Sir has got a total of 59 publications in the international and national journals. And so once again, I welcome all the participants for the CDE programs. And now I request Dr. Satyaranjan Mishra to deliver a lecture on radiographic interpretation and diagnosis, the path to success. Over to you, sir. Thank you.
A very good morning to one and all. Am I audible?
Yes, sir.
And is my presentation seen?
Yeah.
Yes,
Your
sir.
screen is visible.
Yes, sir. So
you make it into slideshow, sir.
Yeah. Greetings from the land of Lord Jagannath. I am from Orissa, and happy International Day of Radiology to everyone here. It gives me immense pleasure to be a part of this program because it's commemorating the discovery of X-rays today. So the topic that I have chosen to speak on is radiographic interpretation and diagnosis, the path to success. Now, we have gone from the 2D era to the 3D with Cbct, as we have Dr. Anand speaking on Cbct, most of the people these days speak on Cbct, but I chose because it's a budding dentist who are the target audience. So I stayed with the 2D, and I'll be talking about the intraoral and panoramic radiographs little bit regarding the interpretation. And this is a very basic presentation where I'll be dealing with some points which may be useful when they start their clinical practice, because we know that clinical practice needs knowledge of radiography and also diagnostic radiology. So I'll be talking about some preliminaries, radiographic views, the normal anatomic variations, and how to go about interpreting. Now, at the outset, I must tell you that radiographic interpretation does not mean diagnosis. So diagnosis has to be with clinical correlation. So to start with, we know Sir has told how Ronjan used his wife as a patient, and her hand was the first radiograph taken. And since then, we have moved a long way. The next year, very next year, 1896, we had the first dental radiograph. It used to take a long time for exposure. Now we have moved from analog or film-based radiography to digital radiography. Though film-based radiography is still being practiced in many parts of India because it is cheaper, and digital radiography requires some initial investment for the dental clinic. So I'll be covering both, or rather more on film-based radiography and some amount on the digital radiography as well. So dental radiography remains or is an integral part of dental practice. You cannot do treatment without this adjunct diagnostic aid. Now, radiographs are two-dimensional structures, so they will represent our three-dimensional tooth and their neighboring areas. So we need to differentiate between the normal and the abnormal. There is some normal radiographic landmarks, a normal anatomy, and the abnormal radiographic changes that can represent disease conditions. So in between, there might be some normal variations which may mimic diseases, but they are actually the normal things. So radiographic diagnosis depends on the expertise and the knowledge to interpret these things. So how do we go about it? First and the foremost is having a good quality diagnostic image. If the image is not proper, it becomes undiagnostic and interpretation is not proper. So when we have these technique errors like elongation, foreshortening, or overlapping, these create a lot of issues in the diagnosis as well as later on in treatment. So many things are missed because of these. The idea is to take a proper radiograph and interpret. And image distortion. Now, this also can happen in your digital radiography, not only in case of film-based radiography, especially when you have a rigid digital sensor there. Other processing errors like development and fixation, which can of course be eliminated by using digital radiography. These happen during processing, and these also create dark or light radiographs which make the radiograph undiagnostic. And a single image is often not enough for interpretation or diagnosis. So these images have to be taken in different angulations. So either you take one radiograph and then the other radiograph is taken in a different vertical or horizontal angulation. Now, considering that we are following bisecting angle technique almost everywhere. And as I've been telling you that radiographs are basically two-dimensional images of three-dimensional structures. So they may not be enough, and we require other imaging modalities like, for example, Cbct or CT, MRI, whatever. And so these represent some of the common errors that we have, having a partial image or a cone cut. That is very common in digital radiography. People think that they can go on repeating, and that also leads to a lot of radiation exposure. That's very common these days. And of course, you have elongation, foreshortening, which can later on lead to, when you are going for endodontic treatment, your canal instrumentation is difficult. Overlapping misses interproximal caries. Distortion again renders it undiagnosed. So what preliminaries are required for a proper interpretation? One is optimum viewing condition. If you're using a digital sensor, then no issues on your computer. You can see the image and you can change the contrast and all. Viewing condition is good. But if you are using a conventional radiograph, film-based radiograph, then you need to use a view box, because that gives you ambient light and masks the other portion of the view box. Only the amount of light required for your radiograph should be seen. So that is really essential for interpretation. We often have a habit that even if we have a view box, we hold the film to the light and check it out. And of course, when you are checking out the trabecular pattern, so you need to have a magnifying glass where you can appreciate the laminar dura, you can appreciate the periodontal ligament space and so on. And conventional radiograph should be dry, because wet radiographs can lead to parallax. Now, radiographic interpretation, so adequate knowledge about the different projections when you need to take a periapical or a bitewing or an occlusal, or for that matter, a panoramic radiograph, the different errors associated, and of course, you need to know about the radiographic appearances of normal anatomy and to differentiate with the disease. So basically, detection of whatever you are seeing, description of those structures, and differentiation between the normal and the abnormal is what comprises of radiographic interpretation. So basically, what the mind knows, the eyes will see. So if you are knowledgeable, you know about the different structures that are present, then it is easier for you to interpret, and you interpret correctly. So it's actually all about density. So basically the radio density, like some structures appear radio opaque and some structures appear radiolucent. Why is that? Because the denser structures like the teeth, metallic restorations, bone, etc., they impede the passage of the X-ray photons to the film and they absorb most of it. So they appear radio opaque or white on the radiograph. And those structures like soft tissues, mucosa, and of course the air spaces, they will let most of the photons pass through, and that's why they appear radiolucent. So it's white and black, or even shades of gray, as Sir was referring to. But however, it is not always easy to know what you see, because we all know that the elephant has 4 legs, but here we do not know which are the 4 legs. So sometimes there will be variations in the normal structures also, which we have to keep in mind. So how do we go step by step? By interpretation of the radiograph. So let's be logical. We localize, localization, observation of the normal structures, some general considerations, finally interpret, taking into account the first 3, and then correlate and diagnose. Now, correlation has to be with the clinical findings and the history. Now, we all know the common radiographs that we use is the periapical radiograph and the panoramic radiograph for that matter. Especially in the times of pandemic, we used to get such radiographs, like most often intraoral radiography was not done because of the infection issue. So people used to be advised either panoramic radiograph or a Cbct. Now that has its own disadvantages, because panoramic radiograph has some amount of magnification. Now bitewing and occlusal are also important radiographs that maybe they are not very often practiced in dental clinics, but they are actually of quite use. Now, if you have a structure which has it's a bigger pathology and you need to know about the buccolingual dimensions, then the occlusal radiograph is the one which require, as seen in this picture. Similarly, if you have a patient who has some issues with a particular tooth, as you see in the periapical radiograph, so there's a radiolucency there with the premolar, but there are some radio opacities associated with the molar as well. So this was not enough. The patient was advised for a panoramic radiograph. There are multiple things that are seen, many dental anomalies, as well as the radiolucencies, and even an occlusal radiograph was advised. So idea is that we can go for multiple radiographs when required. It is not that you have to limit yourself to one radiograph. So localization, basically you have to recognize the view, the arch and the side of the radiograph. Now it's important that sometimes the patient comes to you with radiographs. So if you are not able to identify the arch or the side, then it's actually an embarrassment. So how do we recognize the arch? So the arch, maxilla or the mandible, how do you recognize on a radiograph? There are three things which are useful. The anatomy of the teeth. We know that the maxillary teeth are slightly larger, like incisors are larger than the mandibular incisors. Similarly, three-rooted teeth are seen in posteriors and mandibular posteriors are two-rooted. So anatomy of the teeth helps. The trabecular pattern, we know that the trabecular pattern is different for the anterior and posterior and also in the different arches. So maxillary arch will have more number of trabeculae and they are smaller in size, and larger trabecular pattern is seen in case of the mandible. And of course, there are multiple landmarks that are appreciated. Now, all the landmarks that we study are not seen on the all radiographs. It depends on the annulation. Like in these structures we see here. So can you see that if the anatomy we do not know, then we can get confused. Like this is a radiograph of a dog. So coming back, trabecular pattern, we see that the maxillary and the mandibular trabecular pattern is different. In anterior maxilla, for example, we have a granular pattern with more number of trabeculae, and the trabecular number slightly decreases in the posterior maxilla, but the size also increases. Anterior mandible, we have bigger size trabeculae with horizontal orientation, and they increase in size and are less in number even in the posterior mandible. As we know, the mandible is a dense bone and compared to porous maxilla. So that is only represented on radiographs. Left and right. So if it is a conventional radiograph, you have an embossed dot and that determines the side. Of course, if you have digital radiographs, you know which side it is. Observation. So you start with the teeth and then the supporting structures. Teeth have the crown and the root. So you have the enamel, dentine, and the pulp. Cementum, which is present, is almost indistinguishable with the dentine because it has the same amount of mineralization. Supporting structures, what we need to address are the alveolar crest, the periodontal ligament space, and the lamina dura. So you have the crown of the tooth and the root. Crown has enamel and dentine. The enamel is the most radioopaque, where dentine is, compared to enamel, a radiolucent structure, and the dentine forms the bulk of the tooth. And there's a cementum, as I said, it is indistinguishable on a radiograph, but you can easily find out where is the dentino-enamel junction and the cemento-enamel junction. And of course, you have the pulp chamber and the root canal. And the apex is the most important thing that we require, because for endodontic treatment, that is one important thing. Periapical lesions need to be diagnosed. So you have a radiolucent periodontal ligament space, the apex, and a radio-opaque lamina dura, which represents the cortical bone. So the lamina dura, which is radio-opaque, and the periodontal ligament space, which is radiolucent. Now, both these structures are affected during pathological conditions, like there's loss of lamina dura and there is widening of the periodontal space. So in anatomic landmarks, there are different radiolucent and radio-opaque landmarks in the maxilla and the mandible. And what we see are most of the landmarks, as I said, are not seen in all radiographs. So you need to appreciate that in anterior maxilla, you have the intermaxillary suture, the incisive fossa, the nasal fossa, etc. And the maxillary sinus, the zygomatic process of maxilla, even pterygoid plates, which are imaged on the posterior maxilla. And of course, on the mandible, you require to know where is the position of the mental foramen, because that's below the second premolar mostly, and it is required for, and also the inferior dental canal, which are required while you are going for impaction surgery or implants. or nerve tracing is also an important feature there. So these structures we require to know. Assuming that we all know this, I proceed. General considerations. Many times we see that the maxillary molars, the roots, are seen as if they are present within the sinus. Now, how do that happens? Because when the sinus is located posteriorly, posterior to the roots of those teeth, so they appear to be superimposed on one another, and the roots appear inside the sinus. So how do we differentiate? We can trace the lamina dura and the periodontal ligament space on these teeth if they're actually superimposed. If they're actually in the sinus and there's some pathology, then that would be lost. Similarly, we require to know the position of the tram lines, that is the inferior dental canal, which is represented in the mandible. Why is it so? Because for, say, impaction surgery as well as for placing implants, this nerve location is important. So if the nerve is damaged during an impaction surgery, disimpaction surgery, then what happens? The patient has paresthesia and remains with the complaint for a long time. So these inferior dental canal can be again superimposed on the tooth. So keeping in mind the various radiographic appearances, we need to pursue with the surgery. Similarly, another important consideration that we should have is the cervical burnout. Cervical burnout basically occurs because of the anatomic structures. We find that the crown of the tooth, which has the enamel and the dentine, and the later, the root portion, which has the alveolar bone and the dentine, cementum. So they are more radiopaque than the narrow cervical region of the tooth, because that is less dense. So it allows more X-rays to pass through. So that happens, and you see on the radiograph, there are on the posterior teeth, we have triangular wedge-shaped radiolucent areas which mimic dental caries. So how do we differentiate? How do we know it's not dental caries and cervical burnout? Because it will affect all the teeth. Not only that, it is present only in one portion of the structure, tooth structure. Not only that, dental caries is not smooth. It is rather irregular outline, whereas this would be smooth outline. And most importantly, if the alveolar bone is not present, that is, there's bone loss in periodontitis, this cervical burnout will not be seen. So these are few things that we need to remember regarding cervical burnout, which can be seen on dental radiographs. You have the radioopaque central shadow of the tooth and the radiolucent shadow, which includes the burnout edges of the teeth. Another thing that we need to keep in mind is the Macban effect. So this is not present on a radiograph. This has to do with our eyes, the retina rather. So it's actually a lateral neural inhibitory interaction within the retina of our eye, that is the observer. And basically it's an edge enhancement phenomenon. So where at the interface, say in the dentino-enamel junction, the dentine appears darker than it actually is, and the enamel appears more light or more radioopaque than actually it is. So this also has to be kept in mind while we are interpreting. Sometimes we also need to know that we have an impacted tooth like impacted canine here. So how do we know it's buccal or lingual? So again, we have to take another radiograph. Localization technique has to be done. It can be by taking another radiograph at 90 degrees to it. That is an occlusal radiograph, as you see here. So it shows us that the tooth is impacted lingually. And this is the right angle technique or the Miller's technique. Sometimes, as you see here, the root canal treatment has been done in the first premolar, and the lingual canal or the palatal canal is seen. So buccal canal, if you want to see, you can see by taking another radiograph by shifting the tube on one side. So similar thing can be done with impacted following the slob rule. So if you are shifting the tube, so slob is same side lingual and the opposite side is buccal. So as the tube shifts horizontally, so you find the impacted tooth or the foreign body or the object that you are trying to locate will also shift. If it shifts to the same side, it is lingual. Which shifts to the opposite side, it is buccal. And then coming to panoramic radiograph, now these are radiographs which are commonly advised for screening of anomalies. So say orthodontic treatment or periodontitis, normally it is taken. But these radiographs are not supposed to be taken for localizing some particular localized disease, like say periapical disease or something, because these magnify about 20 to 25%, and these are going to affect your diagnostic skills because there are a lot of soft tissue shadows there. There are ghost images, there are airways which are interposed. So a lot of issues can happen, and these do not represent actual anatomy of. So coming to interpretation, so you have the enamel, dentine, the pulp, the periodontal ligament space, the lamina dura, and the alveolar bone that you have already observed. So you need to check out regarding the density, whether how radioopaque or radiolucent it is. The margins, again, well-defined, ill-defined. Internal structure can be totally radioopaque, mixed radioopaque, radiolucent, or totally radiolucent. The surrounding structures, how they are affected, like say root resorption, loss of lamina dura, imperial space widening, and so on. And of course, this can also lead to changes in the bone. So coming to dental caries, we all know it's demineralization occurs. So you will have definitely coronal radiolucencies or radiolucencies which are seen on the root. So basically you have to appreciate whether these radiolucencies are approximating the pulp or not, because that determines whether you are going for restorative treatment, minimally invasive, or you are going for endodontic treatment. So your diagnosis, treatment there. Similarly, the crestal bone, how it is present also determines the disease. Like we know that 2 to 3 millimeters from the cemento enamel junction is the crestal bone, the crest of the alveolar. So if it is more than that, then it is considered to be periodontitis. So it might be horizontal or vertical bone loss. Again, that represents the periodontal bone loss. And similarly, periapical lesions like periapical granuloma, periapical cyst, or a periapical abscess, all the three can be seen on radiographs. So we know that periapical granuloma and the periapical cyst are well circumscribed radiolucencies. One, the cyst has a hypercorticated border and the size is more than 1.5 centimeters in diameter, whereas an abscess is an irregular, neither radiolucent nor radio-opaque. It's a rarefied area and it's irregular. Again, these things have to be clinically correlated. Periapical granuloma less than 1.5 centimeters, well defined. Similarly, well defined, more than 1.5 centimeters in diameter is radicular cyst. And abscess, as I said, it's less well defined margins. Then you have active teeth, which might have a hyperplastic follicle about 2 to 3 millimeters in size. If it is more than that, you can think the tooth is undergoing changes for developing a dentigerous cyst. Similarly, cementoma or condensing osteitis. So you have structures there, like cemental structures should be attached to the root, and there will not be seen. Your perial space and the lamina dura will not be visible there. Whereas in case of condensing osteitis, you have a tooth which has to be affected by the caries process or the pulp, which is already dead. So you have evidence of that. In addition to that, the perial space is widened or the lamina dura is lost. Most importantly, the root is not connected to the radiopacity as seen in the second radiograph. So it's important because these are common things that we actually observe. Condensing osteitis happens here. We have radiopaque structures which are seen in the periapical region. Many pathoses are seen either as well-defined or ill-defined margins. Generally, if it is a benign structure, we say that the margins are more well-defined, especially when you have a tumor, benign tumor or a cyst, the margins are more well-defined. As it undergoes a cyst getting secondarily infected, the margins might get ill-defined or you do not have a well-defined radiolucency there. And of course, carcinoma, sarcoma, any malignancy is more likely to have ill-defined margins because they grow fast. Of course, you have exceptions like, say, fibrous dysplasia, a developmental condition, yet the margins are ill-defined. You have almost blending borders there. So these things have to be kept in mind. So before giving a radiographic diagnosis, we need to clinically correlate things. Things might be totally radiolucent. Common ones are cysts, which are totally radiolucent, yet they can be dystrophic calcifications there. So you have even odontogenic cysts and tumors, which have structures, calcific structures inside them. Similarly, you have radiopaque structures, like we said, condensing osteitis, and mixed radiolucent, radiopaque, like you have, say, pin box tumor, or you have calcifying epithelial odontogenic cyst, and so on. So some will also be associated with impacted tooth. So that also presents as a mixed radiopaque radiolucent appearance. Now, these things from an oral radiologist point of view, these are more interesting. In common day-to-day dental practice, we generally see impacted teeth, we see periapical radiolucencies and rarefied areas. And so what do these have effects on the surrounding structures? Now, surrounding structures means the root, the bone. So you can have root resorption, you can have displacement of the teeth or the displacement of the root. You can have radiolucencies which are attached to the neck of the teeth, or you can have root resorption there with the roots inside the radiolucency. Similarly, there will be structures which impede the eruption of the tooth. You can have hypercementosis as seen here. So hypercementosis, again, you cannot visualize the lamina dura and the PDL space is not maybe appreciable because of the great amount of radiopacity that is seen, but the root definitely appear bulbous there. You have periosteal reactions, you can have onion peel appearance, you have various sun ray and sunburst appearance, various type of appearances that are seen, but the common ones that we actually encounter is in osteomyelitis, which actually comes in normal clinical practice as well. So you have to check out the bone, the moth-eaten appearance where irregular radiolucency, radio opacities are seen, again correlating with the clinical findings, bone tenderness, bone pain, and swelling. Similarly, you can see odontomes which appear as disorganized radiopaque masses. Often they cause difficulties in eruption. Again, they can be similar to smaller tooth-like structures like compound odontome or complex odontome seen in the posterior teeth region, where they are maybe disorganized masses not resembling teeth. So idea is that structures other than the teeth are also affected. We as dentists, we need to check out not only the teeth, but also the adjoining structures. The jaw bones are also our area, similarly for the temporomandibular joint. Now, one thing that we often do is for a temporomandibular joint disorder patient who comes to a clinic, we advise for a panoramic radiograph. Now, the panoramic radiograph actually does not show us the condyles, although it shows us bilaterally. The condyles are not typically oriented for diagnosis, so you need different views for that. So that needs to be kept in mind. So coming to correlation and diagnosis, now all these radiographic features that we observe, whereas the anatomical structures, be it the landmarks, we have to correlate to reach a radiographic diagnosis. Now, radiographic diagnosis is not final. It has to be correlated with the history taking as well as the clinical examination, because as I have been emphasizing, the radiographic diagnosis represent two-dimensional structures, whereas our teeth and the oral cavity is three-dimensional. So your history taking and clinical examination are actually the primary, and radiographs are only an adjunct. So keep that in mind. I'll show you a few radiographs commonly seen. So sometimes we get radiographs like this. Patient comes, we are planning for an implant or something. So, or the patient has pain in these teeth where they are not endodontically treated, but a bridge has been given. So idea is there's a radiolucency, irregular radiolucency, which is seen. So what it could be? Very often we think it might be a pathology, but we need to know that always things that we encounter may not be pathosis, but they are part of a natural healing process as well. So when extraction is being done, like history reveals, there was extraction, post extraction, there can be something like this. It actually represents a focal bone osteoporotic marrow defect. So the bone quality is not good there, of course, but that is what, it's not a pathosis that needs to be kept in mind. But since if you are still in doubt, then go for a biopsy there. Similarly, we get patients with endodontic treatment previously done. As seen here, patient has endodontically treated incisor, but there's some periapical lesion that is seen. So that can be also part of the healing process where surgical scar might be seen. So idea is to take the proper history and examine clinically for that matter before we come to the conclusion that it is a periapical lesion that is still persisting. Similarly, for impacted teeth, we need to take radiographs and we need to check out how is the position of the root with the inferior alveolar canal, as well as whether the tooth can be easily, disimpaction surgery can be easily done or not, whereas as you see here, the crown is locked with the second molar. So these things again have to be kept in mind while you are interpreting. Common interpreting conditions are your abscesses, where you see there's a hazy, irregular outline. As you see, the pedial space is widened. There is loss of lamina dura in the apex of the mesial root, as well as there is a rarefied area, definitely an abscess, and there is a coronal radiolucency with a focal involvement. Definitely, you can see a lot of structure that is damaged. So correlate with an abscess. Periodontitis, again, we see the bone loss, and it could be generalized. With that, keeping in mind, we need to go ahead with the treatment plan. So we've reached the last slide, that is conclusion. So idea is we should remember the basics. It's a very basic presentation, considering that we need to know the knowledge of the radiographic technique, when we need to take a periapical radiograph, when we need to appreciate that there is a pulpal pathosis there and periapical changes are there. So go for a periapical radiograph. When you need to take a bite wing where there is interproximal caries, yeah, bite wings are to be taken, should not avoid it. Bite wing is actually going to represent the bone levels. It's almost like a paneling technique, so it adequately represents your interproximal caries, or for that matter, the bone loss which is seen. Similarly, you have the panoramic radiograph, when to go for it, when you require a large amount of the maxilla and mandible to be seen. But remember, it's a screening radiograph, so you need not go for a panoramic radiograph when you are thinking of doing, say, endodontic treatment. But of course, it gives you indication if there is a general periodontal bone loss. You can check out when you require, say, both the TMJ and both the maxilla and mandible are represented. You can check out for, say, the nerve and the impacted tooth when it is not visualized properly in case of your periapical radiograph. Similarly, large cysts and tumors, panoramic radiograph may be done in addition to an occlusal radiograph. So occlusal radiograph also gives us a lot of information, especially the buccolingual dimension. When Cbct was not available in many places, they used to go for an occlusal and a periapical radiograph, even with a panoramic for a dental implant. So errors, positioning errors. Sometimes we do not know what the error is and we land up in misdiagnosis or misinterpretation. And of course, the landmarks like the radiolucent and the radiopaque landmarks that we need to keep in mind. So go step by step, no hurry, while interpreting the radiograph. That helps us a lot. And of course, anything that you practice for a long time makes you perfect. So initial hassles will be there. You might not correlate properly and you may misdiagnose, but later on you achieve perfection because the expert was anything but once a beginner. So any subject, you need to be a beginner initially, and later on with time, with experience, more radiographs that you interpret, you become a master of the technique. And so I need to acknowledge my heartfelt gratitude to my teachers from the Department of Oral Medicine Radiology, Savita Dental College, especially Ilangovan sir, who has been a source of inspiration throughout my career. And of course, I must thank my dear students from my college, that is the Institute of Dental Sciences, Bhubaneswar, who have always inspired me to be a teacher. And sharing some of the good moments that I spent with sir during my PG, and the experience has been continuing post PG and even in the time of the pandemic. Thank you so much, sir, for giving me this opportunity. So are there any questions?
Thank you, sir. Sir, it was a wonderful and insightful presentation. Really enriched us on ways of grace, sir. From A to Z, you covered everything. The one are just two ways. Thank you, sir.
Kindly accept the certificate of appreciation, sir.
Thank you. Thank you so much.
Thank you, sir.
Thank you, Dr.
I hand
Suman.
over to Dr. Gomati, and
Thank you, Dr. Suman and Dr.
I
Gomati, for
hand over
having
to
me
Dr.
here.
Keertana. Now I'll hand over to Dr. Keertana and Dr. Nilofo for the queries, sir.
Good morning, sir. There are few queries from the participant side, sir. How to differentiate Macban effect and cervical burnout?
Macban effect is within our eyes, so keep in mind, so that won't go away. That is not present on the radiograph, whereas cervical burnout is typically present on the cervical region, so of the teeth, and that is seen on the films. So cervical burnout, as I have told, it is going to affect all the teeth and typically present in the anatomic location, that is the cervical area, because the crown above has the enamel and dentine, and the root below has the alveolar bone and the dentine again. So the cervical, narrow cervical area will appear radiolucent. So if the bone loss is there, you will not see cervical burnout, but otherwise it can be confused with dental caries. How to differentiate? Because all the teeth present on that image will be affected. Secondly, it will have a smooth triangular edge, that is the periphery will be smooth and they'll appear triangular radiolucencies. And of course, dental caries will be more irregular and it need not be in the cervical region all the time. So that is the way you need to differentiate.
Thank you, sir. One more question. If we encounter a mucus retention cyst of maxillary sinus on panoramic radiograph, can we confirm the diagnosis or should we go for another imaging modalities?
Well, most of these sinus mucoceles, they are not symptomatic most of the time. Patient might give a history of say sinusitis, or patient of mostly will not be aware. So when you see some dome-shaped radiopacity in the sinus, definitely it is a sinus mucocele. For surgery, you need to either take a Cbct. Of course, that gives you the extension better in the third dimension as well.
So one more. What would be the prime diagnosis if there is a periapical changes as a consequence of caries as well as bone loss up to the apical third?
Sorry, I didn't get the question. What exactly is being asked?
So what would be the prime diagnosis if there is periapical changes as a consequence of a caries as well as bone loss, that is up to the apical third.
So like an image I showed, the caries was extensive and there was even a furcal involvement with a lot of bone loss as well as periapical changes. So idea is, as I've been insisting, the tooth has to be clinically appreciated. How is the condition of the tooth, whether it can be restored. If it is doesn't have a lot of tooth structure, it needs to be extracted, then go ahead. Otherwise, of course, the diagnosis depends on the periapical changes. So if you have a lot of bone loss, so it's an endoperio lesion, then the treatment is dictated by the bone that is there.
Thank you so much, sir. Thank you.
Yeah, thank you.
It's a great pleasure for me to introduce the speaker for the forthcoming sessions, Dr. Anand, Professor in the Department of Oral Medicine and Radiology, Ragas Dental College, Chennai. He graduated in the year 2005 from Ragas Dental College, and he pursued his master's degree in oral medicine and radiology from the same institution. He has a teaching experience of around 12 years, has delivered guest lectures at various platforms, and he's a faculty in Master Implant Program and has been part of Noble Implant Fellowship programs. He's also a consultant radiologist for over 11 years. I got to know from his peer group that he had great passion towards radiology right from his PG days. I think I'm sure that has driven him so far. I welcome you, Dr. Anand, to share your expertise.
Thank you very much, ma'am.
Just a moment, Anand. I just wanted to add that he is one of the pioneers of Cbct in Tamil Nadu, Chennai.
Thank you very much, sir. Okay, is my screen visible? Hello? Is my screen visible?
Yes, Anand. Your screen is seen.
Okay. So, happy Radiologist Day. And it gives me immense pleasure to be the part of the program on this day especially. And at the outset, I'd like to thank my ever enthusiastic teacher, Dr. Ilangovan sir, and Dr. Suman ma'am, and the entire organizing team of KS Dental College for inviting me to deliver this lecture on this special day. And good morning, everyone. I am Dr. Anand, who is working as a professor at Ragas Dental College. And this is the another institution where I work. It is Rajan Dental Institute. I joined this institution 2 years after I completed my post-graduation. And probably this was one of the first or second institute in South India to start Cbct. And from the day of installation of the Cbct mission, I had been with them. And initially, I didn't know anything about Cbct. I started to play with the mission, got to know much information only with playing with that software because I didn't know anything. So I couldn't learn much. So I started to play with that. Then I learned. Then I attended a lot of courses to get used with that software. Right now, I could use multiple softwares, and the credit basically goes to this institute. And before going into my lecture, I should thank Dr. Satya who gave an excellent lecture about the basis of two-dimensional imaging and the advantages of these imaging, and to know about a three-dimensional structure. How can we employ a two-dimensional radiograph in two right angles to get a clear picture? So, having that in mind, you'll be knowing about the disadvantages of two-dimensional conventional radiography, where you have the limitations of overlapping. That's the basic disadvantage, shortening, elongations, and all these things that are associated with the two-dimensional imaging modality. And most of his lecture was about a conventional radiography. And when it comes to a digital variant, the images that are captured in the sensors becomes a digital variant. So when it captures in an analog film, that is a conventional variant. Whereas if the images are captured in a sensor, that becomes a digital variant. So when it is captured into digital variant, and each and every detector that are present that within the basic detectors, either a Ccd or a CMOS, are called as pixels, are nothing but the picture elements. And my lecture would be basically about the three-dimensional imaging modality. When we give a third dimension to the pixel, they become voxels. Voxels are nothing but individual volume elements, and it is the third dimension to the pixel. And the principal determinant of the voxel is nothing but the size of the pixels in the detector. So when a two-dimensional array of detectors, nothing but the pixels, are given to the third dimension, it is called as voxels. So with that note, I welcome you all to the voxel vision, where we need to know about a three-dimensional image. So with the basic disadvantages of two-dimensional imaging modality, the imaging modality to see the spatial relationship of all the structures that came into existence was a three-dimensional imaging modality. And the basic three-dimensional imaging modality was the CT. That was the initial invention. In the initial invention of the computer tomography, we had all the spatial relationship. You got the planes of axial, corneal, sagittal, but it wasn't very accessible to all the dental areas. Moreover, we had a limited area of the maxillofacial area where you see more of the pathology in relation to the bone, and hence we didn't want such an exposure to happen to view a pathology that happens within the bone. And moreover, our area of expertise, and rather than the pathologies, the other common areas that can in which the three-dimensional imaging modality can be employed was the implants. To place such an implant, do we need to employ the patient to a computer tomography which has a very high radiation exposure? That was the query. Then came the cone beam computer tomography. This was specially designed to a dental ENT field. So with that introduction, I consider the introduction of cone beam computer tomography into dental or in kind of imagology is a diagnostic breakthrough. Here, it is nothing but a cone beam with the rotational sequence to provide two-dimensional images. Here, it produces only two-dimensional images. With the two-dimensional images, three-dimensional volume reconstructions of the dentomaxillofacial area are taking place. So, it produces only two-dimensional images. From the two-dimensional images, you do certain algorithms. From the algorithms, the transformation occurs to produce three-dimensional imaging variant. Right now, not only it is happening in the dental field, we have much of uses in the ENT. Basically, to look out for not only ENT, that is not only in relation to the maxillary sinus, but also it plays a very important role even to placing cochlear implants. Right now, the ENT surgeons are taking Cbct to a different extent, where they, with the limited area of view, and also with the limited exposure, they can fabricate the cochlear implants and placing it. They place it within the ear. So these are the different variants of the Cbct machines. So from this you can see it looks similar to that of the. You can see it here. It can look similar to that of the OPG. It's similar variant as the OPG, and not only it can be only in a standing position like that of OPG. Can have a sitting position where you can have the sitting position. You can see it's a different band called as an ICAT. You have the supine position also available, similar to that of the CT machines, where supine Cbct machines are also available. It all depends upon the convenience. If you have a very large area, you can even put a larger footprint. If you have a very small area, you can resort out for a standing Cbct machine where it similarly replicates the OPG machine. So these are the different variants of the Cbct machines that are available in the market. So coming to the basic principle of bone beam computer tomography, it is working by the basic principle that the internal structure of the object can be reconstructed from multiple panoramic multiple projections of the same object. So the internal structure of the object is reconstructed from multiple projections of the same object. And earlier I told you that they are only two-dimensional images. So when you are directing an X-ray to an object, it produces a two-dimensional image of the object, similar to that of the conventional variant, where it produces a two-dimensional image. But in this Cbct, these multiple two-dimensional images are obtained. Multiple two-dimensional images are obtained, which are slightly different in angle from one another. And with this multiple two-dimensional images, you have these softwares that come into play to transform it into excellent three-dimensional images. So this is how a two-dimensional image. So you have the source from which the X-rays are sent out. You have the object and you get a detector. You have a detector in which the image gets transferred upon. So looking at this, it looks like an image. If it is taken from the center, it looks like a PSF. If it is taken from the side, it would look like a lateral SEF. So the basic images that are obtained from a Cpcd scan are only a two-dimensional images, probably a different version of a lateral cephalometric image. And as and when the detector and the X-ray source rotates around the patient, you will have different images at different angles. So this is how it is produced. So usually the detector and the X-ray source can rotate around the patient around a 360-degree angle. Some machine will have only 180 or degree angle. So when it rotates around the patient, it produces X-rays. When it produces X-rays, it falls over the patient and then falls over the detector. And these images are called as the basic images. They are called as the basis images. So the basis images, as I said, are a two-dimensional image which are similar to the lateral cephalometric image. But as it rotates, you will get different lateral cephalometric images which are slightly different in angle from one another. And the primary reconstruction occurs in three orthogonal planes. So here I have mentioned the fact that the primary reconstructed images occurs in three orthogonal planes. It is basically the secondary reconstructed images. The primary images are basically a two-dimensional lateral cephalometric images. From the two-dimensional lateral cephalometric images, reconstruction happens in three orthogonal planes, the basic three orthogonal planes. So you have to appreciate the difference between a CT scan and a Cbct scan. A CT scan will also have the same kind of a console where the patient would be put on a gantry and the patient goes inside that, and the detector and the X-ray source rotates around the patient in a similar fashion. So how different is that the Cbct? In the CT scan, the X-rays produced from the X-ray source are a fan-shaped beam. So when it follows a fan-shaped beam, the primary images would be in the version of an axial slices. So when the patient lies down, the X-rays falls over the patient and then it is captured over the detector. And that primary images are called as the axial sections. The axial sections are being transferred. From the axial sections, the secondary reconstructions happens in the coronal and the sagittal plane. Whereas in a cone beam computed tomography, it is a cone-shaped beam. It produces the lateral cephalometric images and produces multiple lateral cephalometric images. They get overlapped with each other. They get processed by this softwares to produce axial, coronal, and sagittal. So the axial, coronal, sagittal, all three are being reconstructed from the same raw data that are obtained from a cone beam computed tomography. Whereas in conventional CT, the axial slices are the primary images. From that, the coronal and sagittal are being transformed. So this is another representation to make you easily understand. It just produces a cone-shaped beam in a cone beam computed tomography, and then it falls over the detector to produce the lateral cephalometric images. Whereas in the CT scan, it produces a fan-shaped beam that falls as a slice over the patient and then captures useful information only from that slice and then goes and deposits over the detector. Then when the patient moves again inside the gantry, again the next slice would be captured. Similarly, the whole slice would be captured. Only from that the reconstructions would begin. So how different are the Cbct and CT images? This is another representation of a Cbct images. In the Cbct images, the whole slice or the whole face as that of a lateral cephalometric image has been captured. From that, it has been sliced and the three orthogonal planes, the axial, coronal, and sagittal. So if the whole loaf of a bread has been cut like this, you will have a uniform distribution of images. Whereas in the CT scan, the slices are already been cut. From the slices, they have been arranged to create the volume. So there will be some discrepancies, basically because of the fact that the voxels, I told you about the volume elements. The volume elements is nothing but the third dimension of the pixels. In the Cbct, the voxels are isotropic. Isotropic means it would be equal in size. So it would be an exact cube where x is equal to y is equal to z. So the voxels would be of uniform size. Whereas in the CT, the voxels are anisotropic. It means that they are slightly non-uniform. The length or the depth would be slightly non-uniform. So the x and y would not be equal to z. So what happens? The axial images are the primary images. From the axial images, one such image, the sagittal images would be a clear image, whereas the coronal would have a slight elongation, basically because the voxels are anisotropic. So this is very important because there will be a slight discrepancy between the axial and the axial sagittal and the coronal image. Basically, the voxels are anisotropic. So to cover up the basics, we need to know about how does it function. So the basic way I already told you, it just goes and hits the object and then it is being captured in the detector. So what should it have? It should have an X-ray production. It should have an attenuation by the object. It's nothing but the object who stands here and the X-rays falls over the object and then the X-rays carry some useful information and then it is detected by the detector. And from the detector, it is being processed and it is being displayed over the computer. So it's with any kind of imaging modality, the same thing happens. So a normal conventional X-rays, the X-rays are produced by the X-ray tube that falls over the patient, basically the tooth, and then it is captured over the film. The same thing happens here. So coming to the X-ray production.
So the X-ray tube that you normally seen in an intraoral machine and an OPG machine would be similar to that. It has a different KVP settings and different milliampere exposure controls depending upon the type of machine that you have in your practice. So as I told you, the X-rays, the detectors and the X-ray source rotate around the patient. So when it rotates around the patient, you would have seen in an OPG machine that it produces a continuous exposure. So as and when the OPG machine moves around the patient, you will have a continuous exposure so that you get the gradual image that happens within the system. But it doesn't happen in such a way in the Cbct machine where it produces a pulsed exposure. So when it produces a pulsed exposure, though the X-ray machine, that is the exposure machine, rotates around the patient for around 12 seconds, not all the 12 seconds will be an exposure time. The exposure time would be reduced. Basically, it is being in a pulsed manner. So it can be either 6 seconds or something like that, basically depending upon the number of basic images that are being obtained. So although the time of exposure is usually an exposure control for the X-ray system, the Cbct, the time of exposure is actually dependent upon the number of basic images. There are different machines in which you can control the number of basic images. Say if I need to have a three-dimensional view of a structure which I don't need to be in a sub-millimeter resolution, then I can opt the number of basic images to be in a minimal basic images. So when I use 200 basic images, what happens? It produces a reconstruction and then it gives you a volume which will not be a complete volume, which will not be a sub-millimeter specific volume, but you will have a volume because that is the need for me. So in such cases, I can reduce the exposure, thereby decreasing the number of basic images. When I need to know about a sub-millimeter resolution, I need to increase the number of basic images. So the smaller the voxel size, the greater the basic images and longer the exposure. Then during the rotation, so it falls over the patient and then it captures over the detector. So falling over the patient is simple. It falls over the patient, gets attenuated by different objects, and then it falls over the detector. So during the rotation of the scan, multiple exposures are taken at fixed intervals. So that is the basic images. And each of these images are the basic images. Once the rotation is complete, all the images are compiled together, and that is called as the projection data. And all the images are compiled together, and this raw images, multiple raw images, which are nothing but the lateral cephalometric images, which are slightly offset in angle from one another, and nothing but the projection data. So these images are captured on the detector, and the signal of this each projection is unique for each and different angles. So you will have a lateral cephalometric images. The next, it would be having a rotation. You will have another lateral cephalometric images, but it will be in a slightly different angle. So each projection is unique for the different angle, and immediately the image data is sent to the data storage. So when you have a pulse, it falls over the patient and then falls over the detector. Once it gets an image, it is immediately transformed or transferred to the data storage so that the detector is cleared to capture the next images along the next rotational arc. So when it rotates, it should capture the next lateral cephalometric images. For that, that previous data has to be cleared. That previous data would be transferred to the data storage so that the next image would be obtained. So as I told you earlier, the total number of basic images depends upon the radiographic preference, and that is possible in only a few machines such as Newtom, ICAT machines. Most of the machine doesn't have that preferences, and also about the scanner's capability. So that depends upon the voxel size that are particular to that machine. This total range varies from 100 to 600 basic images. So I can restrict the basic images either to 100 or to 600. If I use the 600 basic images, the clarity of the image would be very good. But if I use 100 basic images, the clarity would not be so good. So the greater the number of basic images, you need to have a longer scanning time, and hence the radiation is going to be slightly more, but you will have a better quality with the constructed image. So you know about this ALARA. You know about this ALARA is nothing but as low as reasonably achievable. But you should also have the concept of ALAR, where you should be knowing about as low as reasonably practicable. So though you can get an image with a very low amount of exposure, if it is of not of any diagnostic importance, it is not an image at all. So you should have a line between the amount of radiation that you give and also the quality of the image that you get. Coming to the image detectors, there are two types of detectors that are being used. So we finished off with the X-ray source, then it falls on the detector. You should be knowing about the detectors. In the detectors, earlier there are two types of detector that will be used. That's nothing but the charge coupled device and the amorphous flat panel detectors. Right now, most of the machines are coming with the amorphous flat panel detectors, because basically these flat panel detectors comes with this thin amorphous transistor with the scintillator, and hence these units are considered to generate better data sets than the charge coupled device. So when you use a flat panel detector, what happens, besides being smaller and also less bulkier in size, these flat panel detectors will have a minimal distortion of the image at the periphery of the image display. So when you look out for a different Cbct images obtained from charge coupled device and also with the flat panel detectors, the flat panel detector stands apart basically because the margins or the periphery of the images would be very clearly defined compared to a charge coupled device. So because of the Cbct, which has a flat panel detectors, are not only having a very good image clarity, they also have a very smaller footprint because the bulkiness of the detector would be decreased. So I'll show you a picture about CCD and flat panel detector. This is about the CCD, where you can see the detector which is larger in size like this. Can you see the detector which is large in size, which has been replaced by the this flat panel detectors? Can you see the flat panel detector where the detector size has been reduced? So it decreases the size of the footprint. Here it is the same variant of the same mission. Here it is nothing but the Serona mission where you had the earlier variant. It is called as the Comfort. Right now you have the Comfort Plus, which has been upgraded from the CCD to the CMOS, not only to decrease the size of the footprint, but also to increase the image clarity. So you can see a difference between the images that are obtained within the CCD and CMOS, where the periphery would be slightly ill-defined. Here you won't be able to really see the periphery, whereas the periphery would be very clearly defined with the upcoming flat panel detectors. You can see it here. So with that, we will be able to easily differentiate the inferior alveolar node, all the intricate anatomies can be easily obtained with when you have a sensor which has a flat panel detectors. And the other point is, not all machines come with the standard kVp, kilovoltage potential, milliamperes. So different machines are being in the market and they have different kilovoltage potential, different milliampere settings. So though we say that the dose with the Cbct is much lesser than that of the Cbct than with the CT, due to the difference in the variation that are produced by the manufacturers, some machine will have an 80 kVp, some machine will have 100 kVp, some machine will have a 42 milliampere, some machine will have an 18 milliamperes. So you won't be able to exactly calculate the dose basically because though it is less, you have a wide range of doses when you use a lower kVp and a lower milliampere and a higher kVp and a higher milliampere. Not only the dose is affected by these kVp and the milliampere, it's also affected by the limitation factors. That is nothing but the field of views. So many field of views that are available in different missions. Not all missions comes with the same field of view. Field of view is nothing but the collimation. So in a normal X-ray mission, you know about the collimator, which restricts the size of the X-ray beam. If the X-ray beam is limited and it is, if I need to view a structure, if it is for an endodontic views, I need to use see only the forceps. Do I need to subject the patient to a large FOV? I don't need to. So I need to know only about the structure. So the FOVs can be variable from 4 into 4 centimeter. 4 into 4 centimeter. I can decrease that area of penetration of the X-ray only to that area of 4 into 4 centimeter, and that is called as the field of view. And either I can take it only to the maxilla, only to the mandible. If I need to know about the spatial relationship of the both maxilla and mandible, then I need to a full arch. If I need to know about an orthodontic surgery, then I need to have a whole skull view. So all these things are variable with different missions. So next is a chart which shows you the different missions that are available with the different field of views. Here you can see there are some of the missions that are available in the market. They are called the 3D Akitomo, where you have the minimum field of view from 4 into 4 to 12 into 17 centimeter. And this is the minimal voxel size that determines the number of basic images, and the scan time can vary between 5.4 to 30 seconds. As I told you, if I need to increase the number of basic images, that goes to 30 seconds. If it is to a lower amount of basic images, it's just 5.4. And the maximum kVp that is 90. Whereas the other missions would vary. So you can see it here 8.8 and 17 into 23, larger field of view. And the minimum voxel size is this. And you have an exposure variant, and here you can see the difference in kilovoltage potential. So the difference in kilovoltage can vary from, you have, even I have a mission which has an 80 kilovoltage potential, from 80 to 120 kilovoltage potential. And there are missions which use supine positions, and you have a flexi versions. All these things are available. And there are certain missions that comes with the variations where you can even get a two-dimensional panoramic images. So you can see that ICAD Flux comes with the panoramic variant. You don't need to have a separate OPG mission for that. You have the same mission which can give you a panoramic variant. And the Kodak Carestream 9300 has the variant of both panoramic and lateral cephalometric. So you can take both lateral ceph and panoramic, and also in a three-dimensional variant such as Cpcd. So you might also think for the fact that if you know about Cbct, that you would be knowing that I can get a panoramic even with a normal Cbct software. That panoramic is completely different. They are called as reconstructed panoramic. So the primary images would be the lateral cephalometric images. From the lateral cephalometric images, the primary orthogonal planes would be obtained as axial, corneal, and sagittal, and the secondary reconstruction can happen in different planes, out of which one is a reconstructed panoramic image. So it will not be a classic panoramic image, it is a reconstructed panoramic image that is normally obtained with the Cpct software. But these kind of softwares, these kind of missions have a different variant which can produce a separate two-dimensional panoramic and lateral cephalometric images. As a general rule, the larger the field of view, what happens? Obviously, you should have a larger scanner. That is nothing but the detector size should be large, and hence the cost of the scanner would be greater. Basically, as I told, the higher the cost is attributed to the larger detector size and the larger kilovoltage potential generated to produce an image, which shows the denser part of the skulls for orthodontic and orthodontic evaluation. So the choices of images. basically I told you it has been classified as a primary reconstruction planes, axial, corneal and sagittal. From the axial, corneal and sagittal, secondary reconstructions can also happen. So the choices of image depends upon the power of the imaging software and the need and the preferences of the clinician. So if the clinician is very, say, usually I've seen dentists which are more obsessed with OPG view because they are very familiar with the OPG view. So most of the software not only provides you a two-dimensional scan of an axial, corneal, sagittal or a transverse sagittal, whatever it is, it also have a specific function of creating a panoramic view, and that panoramic view is nothing but the reconstructed panoramic view and not a plain panoramic view. So it all depends upon the needs and preferences of the clinician. Most scanners displays the primary reconstruction in the three anatomic planes. So all the softwares will have the same thing: axial, corneal and sagittal. Whatever the software that you use would have the same thing, and you will have specific slices depending upon the power of the software and need of the clinician. So the same volumetric data is used to reconstruct secondary reconstruction. Rather than the primary reconstruction such as axial, corneal and sagittal, you will also have secondary reconstructions. So these are the axial, corneal and sagittal. You know about the differences between axial. So when the object is being sliced and taken it like this, in a transverse plane, you have a axial image. When it is taken along the sagittal suture, you will have the sagittal plane. And if it is taken along the line of corneal suture, it is the corneal plane. So if we are so used with the two-dimensional imaging and getting and used to a three-dimensional imaging modality is slightly difficult on the initial stance, basically because to spatially relate to ourselves to different anatomical areas. So these are the basic images that are obtained. So I also put some basic images that are obtained from different softwares. So this is a software from Sirona, and this software is called as the Galileos. So they are the parent software. So each and every CBCT mission comes with the parent software. What do you mean by parent software? To open that data that are acquired, you have a software that comes up along with the mission, and that is called as the parent software. So this Sirona comes with the parent software called as the Galileos. So in this Galileos, you will have these functions. So when you open the software itself, it just shows you this size of images. So you can see the reconstructed panoramic, you can see a 3D reconstructed image, then you have the tangential, cross-sectional and axial. And when you look at this, you can see implant aligned and MPR radiology. MPR radiology is nothing but the axial, corneal and sagittal. So this would be the primary software of that particular mission. So here you can also observe the fact that you don't have a panoramic reconstruction. So you can see a arch or a jaw-like function here. So when you click on this, you will get a predefined focal trough. So I think all of you would be knowing about the focal trough, where it is called as a three-dimensional curved zone in which the structures would be reasonably well defined. So the areas that are covered in the focal trough would be reasonably well defined, and hence the OPG view is clearly seen. And the minimal window that has been kept over the OPG window is the slicing window, and the slicing window's function. So you can see the slicing window, and this area has been represented in all these areas. So these two are representations of this slicing window, where I have made a slice in that area and I shown it to you. Understood? So you have a predefined focal trough in this kind of machines, in this kind of softwares basically. And you can also have different functions of other software, where you can see the measurement tool, the angle tool, and this is called as the grayscale values. And this is called as the grayscale values. And you can see adjust the contrast, brightness with this, so that if in case of any structure is not very clearly visible, as with the power of the digital imaging, you have the object to you have the power to adjust the contrast, the brightness. That happens with any kind of digital imaging, right from conventional digital imaging to a three-dimensional imaging modality. and hence you can have a better picture. The other things are, you can even make a report. These are primary things that are present with the primary software. You can make a report, you can trace the nerve, you can place a simulated implant. It will not be an exact virtual implant, you will have a simulated implant, and all these things can be planned with the software. So when you ask for a Cbct and they give it as a Cbct image, it will be coming as a CD, and that CD would usually have a primary software. That usually have a primary software. When you open the software, they will have an application file. When you apply the application file, it helps us to install the software in your machine, and then it can easily open the software and you'll have a screen like this. Then you start to play a thon, and then you'll get to know more about the software. But the versions that are given along as a CD would be a limited function shareware. What do you mean by limited function shareware? It's nothing but all functions that are present in the primary software would not be shared to the third party. So if I am having a Cbct center and if I have a master computer which has the primary software, and that is the master computer, that primary computer or the primary software that is present in the primary master computer would have all the functions that are present here. But when I copy it in the CD along with the software and then give it to you for a different use, so that you need to know about a different areas where I have to see the area of the bone, that is bone availability or any kind of pathology, you will not have all the functions that are present within the master computer. You will have some limited functions that are allowed, such as the measurement tool, the angle tool, the grayscale values. All these things are updated. This is one more software. It is from the Kodak Caries screen. You can see the a different screen. So the primary screen would be a different screen here. What happens here? You have an orthogonal slicing, curved slicing, and custom slicing. All these things would be a different screens here. Basically, because this is a different software, and people, it is basically the capability of the software. Here, you don't see a predefined focal trough. You don't see a predefined focal trough. See here, you can have a tool called as the panoramic tool. Can you see it here? They're like that of the horseshoe shape. They have the panoramic tool. In the panoramic tool, you click on the area where you need to assess it properly. Like here, if this is a snapshot, so I'm not helping you with how to assess the panoramic curve and all these things. So here they have made a panoramic curve in relation to the mandible, and the panoramic curve here it is slightly clearly seen. So if I need to see the lower teeth also, I have to raise the area. I have to increase, I have to raise the area and draw the curve properly in that area so that we can see the mandible properly. So in the previous software, you had a predefined curve, and hence maxilla and mandible, since it is a large focal trough, both the maxilla and mandible were seen in relation to a specific structure here. Whereas here you have to adjust the focal trough so that you can see the maxilla separately and mandible separately. The other tools here are the same. You can see the field of view. Here the field of view has been restricted only in relation to the part of the maxilla and mandible. Then you have the measurement tool, the angle tool, and here is the nerve tool. So you can mark the nerve with the help of these two. Right now, the advanced Kodak software have the upgraded version of the software or the shareware, where even the third party vendor can also have a versions of marking the nerve and placing the implant. Then the next software is by the Planmeca. This is another software where the basic window is like this, and it also has a similar version as that of the Kodak software, where you have to trace the panoramic curve. Once the panoramic curve has been traced, then a panorama would be obtained. That's the reconstructed panorama. And the beautiful thing about this newer Planmeca software is that you have a tool to assess the volume. You have a tool to assess the volume. So this tool helps us to assess the airway volumes. Earlier, this was very difficult with all these primary software, but this primary software has a specific function of creating a volume tool where you can assess the airway volume that can be assessed more in relation to the sleep studies, obstructive sleep apneas. And there are earlier a lot of queries regarding whether we'll be able to calculate the volume of the canals, root canals before and after biomechanical preparations. So this can also be tried in with the help of this volume tool, but it was very difficult with this volume tool because it's a specific volume tool used to assess the airway space. So these are different versions of the different software. You can see the axial, the corneal and sagittal, and also a three-dimensional view. This is a limited field of view. I can see the limited field of view where the area has been restricted to around 5x5 area, where the specific tooth in relation to that area, basically for endodontic use, can be captured. Here, when you use a smaller field of view, the exposure to the area would be slightly higher so that the visibility of these intricate structures would be very clear. So when you use a smaller field of view, the additional canals, if in case there is any, that's basically for endodontic use, can be slightly better visualized. When you use a larger field of view and look out for a additional canal, that will be quite difficult. Basically, the resolution of such images would be very poor. So when, depending upon the use in which you use, you have to use a specific field of use. And this is another image where you can see the reconstruct the OPG scan, and also with the reconstruct OPG that is present here. From that, the slices have been cut into a axial, into a right angle planes. These planes are very important to assess for implant. They are called as the paraxial planes, the paraxial cuts. So for an implant, you need not the axial, not the coronal. You need to have the paraxial slice to have an exact cut along the arch, and that is called as the paraxial slices. And these paraxial slices are basically used to assess it for implant. And with some functions that are present within the software, you can even place a implant and you can see how did the position of the implant. So these are the functions of the software that can be transferred along so that the third party can even work along with that. And some machines would have a custom slicing. In custom slicing, you can have a comparison between the right and left side. Here it is from the CAD stream where I made a custom slicing of the axial, both the TMJs. Both the TMJs. So in OPG, you would be knowing about the tomography. You can see the right and left TMJ separately. The same way, even in a Cbct machine, to have a better comparison between the right and left sides, you can have a custom slicing of the Cbct scan where both the TMJs have been sliced like this, and it can be better be compared to look out for erosions and all these things. And this is what I told you about the volume tool that happens in the PlanMaker software, where you can see the area or the total volume that are present in relation to the airway space, so that the area, the upcoming field of obstructive, the sleep studies and any pathology in relation to the obstructive sleep apneas, which are producing multiple secondary pathologies such as hypertension, all these things could be corrected. It can be used even for dental thing, basically because due to the position of the mandible, if a reconstruct or a retropositioned mandible can also produce a obstructed airway that can later lead to a or a bulky patient can also lead to a obstructive sleep apnea. All these things can be visualized with this software. So this is what I told you about the power of this software. At present, a variety of independent third-party softwares are commercially available. What do you mean by third-party software? All the while I will be talking only about the primary software that are available or the parent software. In the parent software that is present along with the machine. But for specific use, there are multiple third-party software. What do you mean by third-party software? Is something a purchased software to see a Cbct image. So what is more specific is that depending upon the use, we can purchase that software. So if I need to place a more amount of implants, there are specific softwares that are available for implants, such as Noble Clinician, Simplant, Mimics. So these are specific software for implants. If I need to know more about, or if I am a specialist who works more about orthodontic surgeries and all these things, there are certain softwares such as Anatomic, On Demand 3D. If it is some software that are related to specific orthodontic views, even Anatomic can be used. So depending upon that, you would have a reconstruction or a third-party software. Right now, you have multiple third-party softwares that are available. Some of them, as I told you, are On-Demand 3D, Noble Clinician, Mimics, 3M softwares. If it is for a specific implant software, such as Roman software called as a cone diagnostic, Noble Clinician for Noble Biocare implants, Simplant software for multiple ranges of implants. So these are the software that are available in the market. So if a third-party software is being used, you cannot use the same primary CD to open it with the third-party software. You should ask the master computer or those who provide you with the CD to give it in a view called as a digital imaging and communication in medicine, called as a DICOM view. So you have to ask them to provide you the same images in a DICOM or third-party DICOM view, so that images can be opened in a third-party software. When you normally try it with the parent software, only the parent software works because it is specifically a coupled up agent along with that of the primary CD that is would be in uptake. Whereas in the third-party software, if you like to open it in a third-party software, you should ask the provider to give it in a third-party DICOM version so that it can be opened. Its third-party DICOM version is nothing but the digital imaging and communication in medicine standards. So it is only a communication tool. So you have seen so much of improvement in Cbct. So you have got even CT scans and Cbct scans, but you have seen a lot of improvement in the Cbct scans basically because of the softwares that have been associated. Why has this software been associated? Because of the dental uses that are more associated with this three-dimensional imaging modalities. So images can be provided in three formats. As I said, it's about the paper, can be given as a print, as a paper, as a CD, and also as a film. And Cbct images are true and accurate. There won't be much of a deviation, whereas a traditional CT scans will have slightly a higher amount of deviation compared to a Cbct scan. Basically, as I told you about the fact that the work cells are anisotropic in the CT scan, whereas in the Cbct, the work cells are isotropic. And the two factors which have played in a big and a rapid role in incorporation of Cbct technology in dentistry is the availability of the cost-effective or rapid computer technology, where you can do multiple programs at the same time. You have an excellent three-dimensional, where you have an excellent graphic card and an excellent RAM. You will have a very good power of the software. Then the second is the ability of the software engineers to develop multiple dental imaging applications. So I think the most common things that are implemented to increase the power of these software is basically the applications that we needed in dental, basically the implant, orthodontic, all these things are the catalyst which help the software engineers to improve our multiple dental imaging applications. So with that, we will discuss about the differences between the CT and computer tomography. I think I have covered about the basics of cone beam computer tomography. So to cover up, you have a CT scan which takes it in slices, whereas in cone beam takes it in cone-shaped beam. So since it is a cone-shaped beam and a lateral cephalometric image, it covers both maxilla and mandible at the same time. It takes different slices to cover both the maxilla. I told you it moves around within the gantry and it takes up in slices. So to cover the maxilla and the mandible takes more amount of time compared to a Cbct. So the exposure time, though it is variable, just put a gross time around 14 seconds. whereas the exposure time is a CT is more higher, and the absorbed dose with the largest field of view and highest MA is around 128 microsievert, whereas in a CT it's slightly going away. But with the advances in the CT that is coming up, you have a multi-detector Cbct, multi-detector CTs. So you have the number of exposures or the absorbed dose has slightly become lesser even with the CT scans. At a higher resolution in all the areas, whereas in the coronal slices the resolution gets lost in the CT scan, but it has a lower contrast that of the CT basically because we use a lower KVP, and hence CT stands good in case of higher contrast. So in looking out for pathologies that are associated not only with the bone and also with the soft tissue, we should always recommend a CT scan because it is a standard to look out for pathologies that are associated with along with the soft tissue. The power of the Cbct to locate pathologies only within the bone. It doesn't have much of capacities to even look out for the adjacent soft tissues. You have in the CT scan, you have a very good contrast, and hence you have a different windows called the bony window and a hard tissue, the hard tissue window and the soft tissue window, where you can see the different pathologies and different styles, so that you can easily appreciate the contrast and then differentiate the pathologies. So the CT scan also has a metal scatter, and you have the stick artifacts that are highly associated with the CT scan done with the Cbct. You have different softwares that are present along with the Cbct. You cannot, so with the help of the software, you can easily trace out the nerve with the Cbct that cannot be normally done with the CT scan. And the volume rendering is possible, and here even in the CT scan, the volume rendering is possible. And since you have a open-ended vision where you can, similar to that of the OPG, it doesn't have a closed case like that of the supine vision. There are different variants that are available, can be used even in claustrophobic patients. And you have a different implant planning, surgical possible, or even possible with the primary software. Whereas in DICOM software, those things are not available. Basically, if it is the imaging modality for diagnostic applications, you also have a user-friendly post-processing software, so that the post-processing server carried to third party where it can be usually seen, and it also it's compatible with the DICOM, where I told you about compatible with DICOM, in which you have copied in a DICOM version can be viewed by a third party vendor with the third party software also. Basic measurements, angles can also be copied. So these are the advantages of Cbct over CT, though it has its specific drawbacks. The basic advantage being the rapid scan time, the beam limitation, lower dose than the helical CT. It is a very compact design, and interactive display modes that are unique to the maxillofacial imaging, and a sub-millimeter resolution. And the limitations doesn't have inherent, it has an inherent image noise, so you will have the clarity will not be as great as that of the CT. Unable to record the soft tissue contrast, as I told you, that it lacks the KVP. The maximum KVP is around 120, and a lesser contrast with the CT, and it produces only grayscale values and not Hounsfield. So I told you in the earlier slides where we can assess even the grayscale value. What is the difference between grayscale values and the Hounsfield? Hounsfield units are the standard which helps us know about the density of the bone. You have a standard Hounsfield unit for 0 for water. For bone, you have a different Hounsfield unit. Depending upon the Hounsfield unit. So for dental use, these Hounsfield units are very important basically to know about the density of the bone, because the density of the bone is the primary factor or the determinant to know about the primary stability of the implant. When I need to place an implant within the bone, the person will ask the radiologist to know about what would be the density. So ideally, the density cannot be calculated with the Cbct software, because the Cbct software shows you only the grayscale values, and it doesn't show you the Hounsfield unit. According to the Hounsfield unit, the density have been differently modified as D1, D2, D3, D4, according to MISH system of grading, where D4 is osteoporotic and D1 is a dense cortical bone. So it can easily assess you about the density of the bone in the CT scan, whereas in the Cbct scan, it doesn't help you to assess the quality of the bone. So with prolonged use, you will be getting used to grayscale values to have an assumption about the quality of bone. Though there are different machines that are available with the different versions of 80, 120 kilovoltage, different milliampere setting, different field of view, what happens is that we couldn't construct a formula which can convert this grayscale values into Hounsfield units because everything is a variant. So even though that doesn't have a formula, there are certain efforts that have been made to convert the grayscale values into Hounsfield unit, and they are called as corrected Hounsfield units. So any Hounsfield unit that is obtained from a CT scan or a Cbct scan is called as a corrected Hounsfield units and not a original Hounsfield units. So that doesn't help us to assess the density. Then comes the last part of the basics where you have the introduction of artificial intelligence into Cbct. So these are some of the softwares that are used to know about the artificial intelligence. Artificial intelligence is nothing but machine learning. You give the machine a lot of data to just stuff in, and then you know if it is a pathology, if it is as Dr. Satya told, if there is a pathology in relation to the posterior region, or if it is in relation to the anterior region, if it is a circular area less than 1.5 centimeter, it is a peripheral granuloma. If it's greater than 1.5 centimeter, it is a peripheral cyst. So if it feed every data to the computer, it just diagnoses by itself. And that is called as artificial layer. These are some of the softwares that are available in the market right now for a Cbct machine, Cbct. So when you feed that into this into the software, it just gives you excellent result. Depending upon, say here, I've just put you a sample. Here, each and every tooth would be assessed by the software. So we cannot do that manually because it is going to be a very tiresome thing, but the software does it excellently. But I don't support artificial intelligence basically because it should be always overlooked by human intelligence because it can make mistakes. So here in relation to 1/6, it shows you how many roots, 2 roots and 3 canons, and periodontal bone loss, a smile in relation to each of these two. There is a chance of filling by 93%. The signs of caries is by 56%. So all these would be visualized with each and every tooth can be visually visualized with the help of the artificial intelligence software. So here it can show you a chart where it show these are the healthy tooth and these are the missing tooth. And in the missing tooth, what is the length of the bone that is available? In the healthy tooth, in the pathological tooth, what are the pathologies that are present? All these things are clearly kept apart with the help of this artificial intelligence software. So these softwares, as I told, DiagnoCAD, NTAI are normally present as an initial trial softwares also. At 1 or 2 cases, you can even try for both OPG and Cbct. I think you can try a DiagnoCAD, NTAI, both for an OPG and a Cbct, and then 1 or 2 cases can be used as a trial, so you will be able to know about the power of artificial intelligence with the help of this. So with this, I wind up the first part of the session.
Thank you, sir. Sir, there are a few queries. Want to take up the queries now, sir? Or shall we do it after the second presentation, sir?
I can hear you.
So there are a few queries, sir. Can we have queries now or after?
Yeah, anything's fine. I couldn't hear you properly, ma'am.
Am I audible?
You are audible right now.
Am I audible now?
You are audible now.
Yeah. We'll just take a break of 10 minutes.
Okay, ma'am.
We'll resume back. It's 11:32 now. At 11:40 shall we resume back, Anand? Is it okay with you?
Yes. Fine.
Okay. We'll take a short break.
Okay.
We welcome you all once again. Dr. Anand, there are just 2 queries, ma'am. Shall we take up the query session after you complete this session?
No, we'll finish off now itself, ma'am.
Now itself? Okay, just a minute. Just give me a moment.
Sir, good morning, sir.
Good morning.
Sir, there are queries from the participants. Which is the best view for TMJ in Cbct and CT, sir?
TMJ in Cbct, I told you about the custom views that are present in the Cbct missions, where you can slice the right and left TMJ and then visibly see the CT. In a CT, you have the orthogonal slicing, where in orthogonal slicing, you can cut it in a curved plane. Say, rather than the primary axial, corneal, and sagittal, you have one more slicing called as the orthogonal slicing, where you can tilt the slices into any desirable planes. In a CT, you can do that. So it can be used in a normal free function shareware that is present with all the Cbct, all the CT images called as the DICOM, or you have something called as a radiant DICOM viewer. In all these things, you have a orthogonal slicing where you can use to see it, see the temporomandibular joint.
Thank you, sir. One more question. For research purpose, in respective of segmentation software, which is good, sir?
For research purpose, see, there are, as I told you, none of the Cbct softwares comes with a very comprehensive patterns. Some comes along with the only a specific views. For comprehensive versions where you have to do a segmentations of a specific areas, you have only third-party variants that are usually present. Even in Osrix, you have some that is basically for a Mac view. You have the specific segmentation areas, and even in the recent version of PlanMeca, you have the segmentation, but have to look out for that area and then let know. If in case if the participant has still more queries, you can give my mail ID so that I can help them with the segmentation.
Thank you so much, sir.
Anand, I have a question.
Yes, sir.
Is there a machine currently available with different FOVs?
Yes, sir, we have it, sir. We have the Kodak Carestream has come up with different FOVs.
I mean, what I mean is with smaller FOV with less exposure and like that, or the exposure will be the same?
No, sir, there are missions with lesser exposures also.
Okay. Because most of the machines currently available, they have a fixed FOV. Whether you ultimately you are going to use a particular segment image for your diagnosis, but the patient is exposed throughout. I mean, the entire patient's head is exposed.
Yes, sir.
Right?
Yes, sir. But in smaller FOV missions, you have only that particular area that has been exposed, that has been present in the probably in new terms, sir.
Okay. Yeah. That's what I'm asking. Can you alter the FOV so that the patient can get less
exposure? Certainly, we can do that, sir.
Yeah.
But not available. See, as I told you, we have different ranges of missions that are available in the market. Only in specific missions that options are present.
Right. Thank you, Anand.
Okay, sir.
Thank you, Anand. You can resume with your presentation.
So the next part of the presentation would be applications of Cbct in different fields of dentistry. Obviously, this Cbct is into all the fields of dentistry. Now, in all the departments, you have the specific purpose of Cbct, and also it has right now come up with forensic applications also. So most of the applications Cbct has a role. So coming from our department to diagnosing pathologies, it is used to diagnose pathologies that are particular in relation to the maxillofacial region. Starting from the simple areas of impactions you know about, the areas that have been in fact where Dr. Satya told about if in case if it is impacted, you used to use two-dimensional radiographic images to ascertain the position of the impacted tooth. But even by ascertaining the position of the impacted by ascertaining the position of the impacted tooth. But even with the two-dimensional imaging modality, you know it can be present buccally or lingually, but the exact position in relation to the adjacent tooth, if in case I have to remove the tooth without damaging the adjacent tooth or the vital structures that are underneath, that cannot be visualized with the normal two-dimensional imaging modality, even though if it is taken in 2 or 3 different angles. So for that, you need a 3-dimensional imaging modality. So this is a simple case where an impacted tooth, where you can see a segmented version of the same area where I use the volume reconstructions to see the impacted tooth and the relationship with the adjacent tooth. So it gives you a clear idea how to proceed with the treatment. And can be used for any number of jaw pathologies, right from ameloblastomas, CVOCs, any cyst tumors. All these things would be ascertained with the help of this job, right from any imaging modality. That is the same thing, that if you know how to interpret it well, obviously you will be able to interpret the same thing even with the 3-dimensional imaging modality. So this is a 3-dimensional version. And here is a case of a staph cyst, where you can see if you can see a radiolucency, you would have seen it more in relation to the posterior region in relation to the OPG. But when you look at it in a 3-dimensional version, you can see a beautiful version of the salivary gland that has gone inside the submandibular gland space. That is the myloid area, between the myloid area, and then engulf that region. You can easily see and then easily differentiate and can easily understand that it is not a true cyst. It also helps us to differentiate between, say, if in case your patient is a very old patient and you see a radiolucency, that can be usually said that it is a staph cyst. But can that be a metastasis from the different region? For that, to be sure, you need a 3-dimensional imaging modality, and it helps us to visualize that. Here is a case of an osteo. Say most of the cases are my cases that I have taken in my course of experience with Cbct. Here is an osteoma in relation to the frontal sinus. You can see an increased mass of bulk of tissue, bulk of a bone in relation to the frontal sinus. And here is also an interesting case of an osteomyelitis of a young patient, where you can see not only the periosteal reactions that are present in osteomyelitis, but you can see the 3-root pattern. You can see the buccal root, which has been divided into 2, and there is one more lingual root. The 3-root pattern of the premolar and the area of periapical pathology that are associated with it to produce an osteomyelitic changes. Then to a simple case of silolith, where we have conventionally used occlusal radiograph to find out this, can also be well visualized with that of the bum. But you should be knowing that only if it has been completely calcified, you'll be able to visualize in a radiological imaging method. And this is one more case where this is a case of a cherubism, where you can see the bilateral expansion, the teeth floating in air appearance, and it is especially used in case of trauma, basically in relation to any kind of a fractures of the maxillofacial regions, because Cbct has the capability to tilt or cut it in any imaginable plane. So if you have to cut it in any imaginable plane, I can cut it and see along the axis Usually in the fractures in the two-dimensional imaging modality, that cannot be sometimes not visualized because the X-rays path along the line of fracture. But here, it can easily visualize the fractures. Here is one more case where you can see, do you find any pathology here? It is an OPG that is taken for the patient after an incidence of probably a road traffic accident or anything. The patient is suffering from pain. And this patient has been subjected to OPG, but we didn't have much of information from the OPG basically because of the inherent limitations of these OPGs. Then the same patient was subject to a Cbct to find out that it has had a diacapitular fracture. A diacapitular fracture, usually a fracture happens in relation to the neck of the fracture, and usually it is said that it's a God's given gift where the neck easily gets fractured so that it prevents a damage to the temporal area or the middle cranial fossa, so that the neck easily gets fractured. But if the condylar head as such gets fractured, it is called as a diacapitular fracture that can be easily visualized with the same patient where the not much of abnormalities were detected with the help of an OPG. This is a bilateral condylar fractures. You can see the exact bilateral condylar fractures with the central fracture in relation to the area, or it's called as the Gottsman fracture, where you can see the three fractures that happens at the same time, the symphyseal region and the two condylar regions. And also in case of TMJ disorders and ankylosis, you can usually visualize whether it is a bony ankylosis or a fibrous ankylosis can also be visualized with the Cbct scan. So if in case you find a segment of radiolucent area that is present between the upper and lower compartments of the TMJ, it is only a fibrous ankylosis, when it is a complete calcification that happens between the temporal and the mandibular bone, you have the complete ankylosis. And not only about that, you can also know about, say, if we have a fracture like this, usually ankylosis, you would have learned the fact that ankylosis can happen after the incidence of a trauma or a fracture. How does that happen? It helps us to understand the fact that, see, you can see a segmented fracture that is pushed off medially. Later it leads to hematoma, but later gets calcified to produce a large mass. Why does a large mass get formed in ankylosis? Basically because of these fractures that can get deviated, and then when a hematoma gets calcified later, that forms. So that helps us to know about the pathophysiology of these fractures, of this ankylosis also. And in case the usual field, the basic field that Cbct is right now mastering that area is the implants. It helps us to know about the area of the bone that is available for implant. Not only for that, the assessment of inferior alveolar now. There are certain software which helps us to know the placement of the inferior alveolar. Already in the previous software, I told you how to measure what is the tool that is used for drawing the inferior alveolar nerve, where we go to different sections. In the different sections, you trace the nerve as such, and then connect it with dots, and then trace it from the medial surface of the mandible to the mental foramen region. So if we do it like that, you will have a complete course of the nerve, which helps us to know whether we are encroaching the anatomy. There are certain softwares that helps us to connect the nerves automatically. As I told you about the core diagnostics from Straumann. It has a software which has the power to connect the nerve automatically if you just click on the two extreme ends. If you click on the two extreme ends, so right now I have to click it in relation to the mental foramen. The other end would be in relation to the mandibular, the entry in relation to the mandibular. So if you click on, but only if the nerve is very clear, this software would have the diagnostic power to connect it automatically. If not, you have to obviously overlook it. That's why I told you artificial intelligence can never master human intelligence. And in endodontics, It is used to diagnose different additional canals. You can see perforations, external resorptions, as I said about the volume of the canals. All these things can be visualized. See, here's a GP that has been pushed along the canal and then it goes towards the apex. If you take a regular conventional radiograph, what do you think? It looks like a completely obturated canal, but it still has a pathology. But here, it gives you a guide that the GP has penetrated to the buccal surface and then gone to the apex, giving you an illusion, or in the conventional radiograph, that it is present till the apex of the tooth. So, yeah, three-dimensional imaging modality is far way better, not in all cases, but in cases of importance. Here is a case of an external resorption that can be easily visualized with that of the Cbct scan. And also for assessment of bone for implants, you know about the lack of bone, you know whether you need to, before you venture into implants, you will be able to know whether I need to do some augmentation procedures, or I can place an implant and then do an augmentation, or before implantation I need to do some bone pickup procedures, only then I can place an implant. All these things can be visualized with the help of this normal Cbct software that comes along with the parent applications. And it is the duty of a radiologist not only to look at into the dental structures, because when you look out for a field of view which covers both maxilla and mandible, or certainly in the larger field of view from the right from the skull area to the neck, it becomes a duty of radiologists to look out for structures that are covered in the scan. You cannot just simply say that I can visualize only the maxilla and mandible, because as such as it is being covered in the scan, it should be visualized. So earlier I told you about the osteoma in relation to the frontal sinus. Right now this is another case where the patient as such has to be subjected for a non-conventional implant. A non-conventional implant in the sense, higher grade implant we call as a zygomatic implant. And it has to be subjected only under general anesthesia. And this patient came to me for reference to plan for the zygomatic implant. Once I planned for the zygomatic implant, then I examined even the throat region. In the throat region, I could see a mass of tissue, the mass of bone that is present in relation to the throat. It is nothing but the calcification of the anterior nuchal ligament. The calcification on the anterior nuchal ligament usually doesn't produce much of a symptoms except for a very mild dysphagia. But if it not been found earlier with the scan, the intubation would have been very difficult for a general anesthesia procedures. So these things has to be taken into account. Though you look out for the maxillomandibular structures, anything that is being covered in the scan has to be looked out for when you are looking out for the field of view. Or depending upon the field of view, it is the radiologist's responsibility to give you a detailed report regarding that. So coming to how to measure, I told you can measure it from the measurement tools. From the measurement tools, as I told, you have the line measurement, the angle measurement. Usually when you have been asked to give a report, how do you give? Basically from the crest of the bone to the nearest anatomical landmark. If it is from the anterior region, the nearest anatomical landmark would be the nasal area. For the posterior region, it would be in relation to the maxillary sinus. The same way in relation to the mandible, the nearest anatomical landmark in relation to the mandible in the posterior region would be the inferior alveolar canal. In the anterior region, sometimes the lingual canal can also be the lingual foramen can also be a problem if it is a larger size. Usually if it is a smaller size, you don't need to consider about it. If it is larger size, if the implant encroaches the lingual foramen, you land up in a large hematoma. So these things has to be visualized properly. So here is the case of a lingual foramen which is very large in size. This an abnormal variant of the lingual foramen where it is present in larger size. If it has been encroached, you land up in a larger. Usually you don't place a midline implant, but in cases where there is a necessity, you have to do. In such cases, you can plan it so that you can bypass the lingual foramen. All these things can be visualized in a third-party application. So here is one such third-party application where I place the implant in a different axis and I use the angulation, angled abutment to give the implant screw head in relation to the prosthetic screw axis through the cingulum, thereby not interfering with the function in aesthetics. The other abnormalities that can be seen in relation to the mandible, is the bifid canal. You can see the canal that has been divided into two. Can you see it clearly here? Sometimes you might get a confusion whether it is a mandibular canal or the trabecular pattern, because sometimes trabecular pattern of bone can also mimic mandibular canal. In such confusions, you have to trace it all through the other sections to check out whether it is continuous. If it is continuous, obviously it is a mandibular canal. If it is not, obviously it is a narrow defect or the trabecular pattern that gives you an illusion of the mandibular canal. So for that you have to trace the points starting from here. You trace it the next section through the axial, corneal, sagittal. You can use any of the section to check out for the alveolar channel and then the nerve channel, and then connect those dots to obtain a. And these are some of the third-party applications. Here you have used a third-party application here where I have, see, if it is a complete denture and if in case the surgeon asks since most of the persons here are radiologists, if the other person from a different field asks you what is the position at different regions, will you be able to assess it in different regions? You don't have a standard landmarks to know which is 1-4, which is 1-2, which is 1-3. If you assess it in relation to 1-2 and then give it to the surgeon, he would put it in relation to 1-3 and say, I didn't have much of bone there. So to counteract that, there are so much of third-party software that are available. Here is one such third-party software where I have reconstructed denture. This is called the radiographic guide. Reconstructed the denture. The same denture has been fixed with the patient mouth, and the denture is scanned separately and the patient is scanned separately, and with the help of the markers that are present in relation to the denture and in relation to the patient, they are both overlap. Right now I know what is the position of each of these tooth. I know I have made a section through one. I have made a section through one. I know what is the amount of bone, and I can easily measure what is the amount of bone that is present and then go to the implant library and then place an implant there. I know what is the, if I need to engage the more amount of bone in relation to the implant would be in this axis. So what happens? The abutment would be coming here. So if I give an abutment like this here, what would happen? The function or the aesthetics would be compromised. So I need the abutment axis to be more in relation to the cingulum so that it won't be seen outside. So I need what kind of angulated abutment can be used to bring the prosthetic screw axis through the cingulum can also be identified here, measure the angle here. So these are the excellent applications of these third-party images, and not only it helps us to know about the position of this, what side of abutment. So before you procure, you ask the surgeon to procure only this size of implant, this size of angled abutment, because each and every inventory is very costly. You cannot buy everything and then keep and then try it for each patient. So you would be having an adequate plan and then you execute it properly. So here I have measured it and I have taken it from the implant library and then placed the implant and then placed it. If in case, if you don't have these kind of softwares, what can we do? Here we can do another technique where you place it a gutta percha, because the denture is not going to be clearly visible unless you have a third-party application where you have to match the isodensity of the denture with that of that. In the earlier slices, I told you the denture is visible, but here normally a denture would not be visible unless you have a third-party software where you would have an isodensity which can be easily picked up by the third-party software. For that, you place a similar denture and then you place a markers in relation to the proposed prosthetic screw axis. Here I have made the markers in relation to the cingulum and also in the posterior region of the back tooth. So the gutta percha has been placed till the apical layer, till the base of the denture, and then a scan can be obtained like this. Once a scan can be obtained, we'll be able to know what is the position of the marker and what is the position of the bone. So depending on the position of the bone, the angulated abutment can be easily calculated, even with the normal Cbct software, if you apply all these techniques. And with the advent of the power of different digital imaging power, you have so much of applications that are available in third parties. Here you have a combination of an intraoral. This is an intraoral scan where it is just like a camera which covers both the maxilla. It's just like a digital impression. Once a digital impression is taken, that can also be merged with the Cbct. So the digital impression has been merged with the Cbct. Once it is completely merged, it shows you whether the merging is proper or not. I will get a good merging. Once the merging is proper, you can plan. Not only plan, you actually place the implant. You know what is the position of the teeth, and you can assess the size of the teeth. What is the size of the teeth? So before going into surgery, this Cbct, with the help of these softwares, which helps us know what it could be the size of the teeth, what should be the position of the prosthetic screw axis, and even you can, because of the you have other things that are coming up with the Cpcd scan, you have the capability to furnish or even fabricate with the 3D. So with the help of the 3D printing, you can plan it. Not only you plan it, you make a 3D guide or a guide, and then it can be placed within the patient mouth, and then you can absolutely place an implant depending upon the proposed axis, and you will have an excellent surgical predictability. Not only with that, you will also have a prosthetic screw and a crown that can be easily fitted over it immediately after them. So all these things have been made possible only with the power of the Cbct and the softwares that have been associated with it. So in cases of advanced implants also, that it has to be used, where this is the case of an all-on-4 technique where the implant in the posterior region has been tilted. So as radiologists, you should be knowing not only about the anatomy that is present in relation to the, because of the upcoming uses of the Cbct, you should also be aware of the upcoming development that happens in different fields like oral surgery, prosthetics. You should also have an idea about all these things. Only then you will have an upper hand when you are planning such implants. So here you can see the inferior alveolar nerve that has been turned like this. That is called as the anterior loop of the inferior alveolar. All this while we would be knowing about the loop that comes anteriorly and going backward. Does it have any significance? Yes, it has some significance when you place an implant in such scenario, because you should not be damaging the loop in places of the implants that are placed in relation to the anterior region. So nearly 60% of the cases would have an anterior loop, and this even has to be traced, even if in case if the somebody is asking you to look out for an all-on-4. And the other thing is about double mental foramens. Even for double mental foramens, has to be visualized. And this is another non-conventional implant where not only we are restricting ourselves in relation to the, not only we are restricting yourself in relation to the maxillary arch. If in case there is no bone in relation to the anterior region, you might even request to plan an implant in relation to the zygomatic bone. So here is a case where we have planned an implant in relation to the anterior region with meso-conventional implants and non-conventional. Here is one more case where you can place 2 zygomatic implants. See, these things has to be measured only by a radiologist to know what is the adequate amount of bone that is present in relation to the zygoma. If in case only if there is a good amount of bone in the zygoma, only then you will be able to place implant, because that is the only structure that is available for the patient to place an implant. Even if you don't know about the anatomy and the surgeon directly ventures into it, if he loses bone, you cannot place an implant even. So all these things has to be assessed prior before you have to. This is one more interesting case where not only the anatomy has to be visualized, there is any changes in the anatomy also has to be visualized. You can see the infraorbital canal that has been completely pushed laterally somewhere in relation to the lateral part of the zygoma. Usually it should have been here. So if it had not been noticed here, initially this place was planned for 2 zygomatic implants, but we couldn't place 2 zygomatic implants basically because of the fact that the infraorbital canal has been pushed too laterally, and this is the picture of that. Can you see the zygomatic implant that is placed there and the infraorbital canal that has been pushed laterally so that there is no space for the other implants to be placed. So coming to the conclusion. So the Cbct scans can provide more accurate and generate less radiation in accordance with the Alveolar principle, and hence it is a preferred modality with compared to any kind of 3-dimensional imaging modality. With the advent of these upcoming softwares, and also because of the need of these dentists, Cbct is almost completely going to revolutionize dental radiology and will have an impact on all aspects of dental practice. I thank the management and the organizers for conducting such an event on the occasion of Radiology Day and inviting me as a speaker. Thank you very much. Any questions? Open to it.
Thank you so much, Dr. Anand.
Thank you.
Very comprehensive presentation with emphasis on both the basics and the applications of Cbct. And I'm very happy that the program has been recorded and it's available in YouTube for future viewing. It's definitely worth going back and listening to all the 3 lectures. Thank you so much, Dr. Anand and Dr. Satyaranjan. Kindly accept our certificate of appreciation from our side. We'll mail the certificates to you.
Okay, ma'am. Thank you. It's good that we have conducted a program even with this bad weather.
Yes. Ishu, thank you. Actually, I was worried when you said there's power cut. And,
so that's why I couldn't make much of a presentation in relation to the applications, because most of them are stuffed within my laptop. And since there was complete power cut in the area, I couldn't make it up.
No issues, ma'am. Thank you so much. You have anything to say for the upcoming radiologists, ma'am? I'm sure PGs are there in the forum now.
So obviously, ma'am, that's what I told you. It is, though we consider ourselves as radiologists, most of the Cbcts and have been purchased and have been practiced only with other fields. Basically, because as radiologists, we sometimes lack the knowledge in different aspects of dentistry regarding implants, orthodontic. So we should enhance ourselves in our knowledge to have a acquaintance in different fields so that we will excel ourselves in our own field.
Dr. Satyaranjan, you have anything to say?
Well, I should thank Dr. Anand for this wonderful presentation, since it's really, the basic part was very interesting, like the softwares and all. So thank you. And regarding, I always believe that we should start with 2-dimensional and then move on to 3D, because it should not be that 3D is taking over 2D, because dental clinics should start with 2D first. And of course, we as oral radiologists, we need to know that Cbct is for us, not that other specialties dictating us that we want this, we want that. We should tell them that how it best benefits them. So we should be the boss rather than they telling us what to do.
Thank you so much, Dr. Sandhu. Now I ask Dr. Keethanath to. Dr. Keethanath can start with the queries, ma'am.
Good afternoon, sir. This question is to Dr. Anand, sir. So, which is the best software for pharyngeal airway analysis?
Pharyngeal airway analysis, you have on-demand 3D. I cannot say which is the best software because I'm not here to promote any softwares. Thing is, best software is the software that you use or you are comfortable with would be the best for you. First thing, the softwares that you are used to would be the best softwares for you. And for airway analysis, you have software starting from PlanMaker, which has a primary software, and on-demand 3D, it can also be a third-party softwares can be used, and even Anatomage can also be used.
Thank you, sir. And one more question. In Cbct software, implant planning oral medicine report.
In Cbct software, implant planning oral medicine report, in the sense, as radiologists, you should be having a perfect format in giving a report, starting from what kind of KVP that you have employed, what is the region or the field of view that you have covered, what are the other findings other than the region of interest that you have, then comes your region of interest. If in case the region of interest is in relation to the implant region, that is in the edentulous region, then as I said, you have to measure it in different areas, starting from the crestal or the subcrestal region, where you have a millimeter, enough width for implants. So normally you have implants starting from NP to WP. NP is nothing but the narrow platform, whereas WP is the wider platform. So in NP, at least 3.5 millimeters should be available. At least in that area, 4 millimeter area, you should start with the crestal width, then going to the anatomical landmark, what is the height that is available. That's what you have to give. And some people do give along with the density. As I told, density is not particular with the Cbct, and it is a corrected Hounsfield units and doesn't have quality, cannot be assessed with the Cbct.
Thank you, sir. And one more question. In Cbct analysis, in artificial intelligence in India, what are applications and what can taken for PG research thesis, sir?
See, in artificial intelligence is just a software. You can compare the outcomes of different softwares. You can compare it with the manual thing and then do it. So this would be the research perspectives. Whether the artificial intelligence has worked well or not with your case. It is just an upcoming field where the data has been collected and has been given to it. So it gives you a perfect report, not a perfect, it gives you a complete report. I cannot say a perfect report, a complete report for each and every tooth and each and every area. That usually a human cannot do. But in cases of particular areas where you have doubts, you can always go back and check in relation to the scan to know whether there is any discrepancies from the report that are with the artificial intelligence and the human.
Thank you so much, sir.
Thank you.
Thank you so much, Dr. Anand. Dr. Ilangovan, sir, you have anything to say, sir? Anything to add on? I think sir is not there.
Yeah, I am there.
Okay. Sir, you have anything to say, sir?
I mean, it's I learned a lot from both lectures. Okay, I sent Anand a message that I felt like a third year PG student who knows something about Cbct then suddenly realizes that there is a lot to be learned. That is for any aspect, especially CBCT, when I heard Anand talking. And of course, Satyaranjan took me back to my UG days, or rather my early days of teaching, where I slowly evolved my own teaching into a useful process to the UG students. So it's on the whole, it's a very academically satisfying experience. Thank you.
Thank you very much, sir.
Yeah.
Now I request Dr. Sendil, professor in our department, to deliver the vote of thanks.
A very good afternoon to all. On the behalf of KSR Group of Institutions, it is a great honor and privilege to deliver the vote of thanks. First and foremost, I thank our distinguished guest speakers of today's CDE program, Dr. Satyaranjan Mishra, Professor and Head, Department of Oral Medicine and Radiology, Institute of Dental Sciences, Shiksha, Anushandan University, Bhubaneswar, and Dr. Anand, Professor, Department of Oral Medicine and Radiology, Ragas Dental College, Chennai, for not only sparing their invaluable time, but also for enlightening us with their commendable talk on the subject. I thank our Vice Chairman and Principal for their support to conduct this program. I thank all the invitees present here accepting our invitation, and heartfelt thanks to Dr. Ilangavan sir, Head of the Department, and Dr. Suman ma'am, Vice Principal, and my colleague faculty members for giving me the opportunity to give vote of thanks. Thank you all for your support for making the CDE program a success. Thank you.
We, the Department of Oral Medicine and Radiology, thank Dr. Prasad, who's been the backbone behind all this. He's helped us a lot in conducting this program in a virtual platform. Thank you, Dr. Prasad. And I thank all the participants once again. And I humbly request you to fill in the feedback forms, and all your certificates will be mailed to you shortly. Thank you so much, one and all. We'll bind this session. Thank you.